Good afternoon. What a great day we've already had, and I'm really excited to share with you our next presenter. Our final speaker for today's Help and Hope Symposium is Dr. Mary Sedarous from the Hackensack Meridian Health Jersey Shore University Medical Center. In 2023, we recognized Dr. Sedarous and her team with our Flame of Hope for ALS Research and Innovation. Dr. Sedarous established her clinic in 2016. It has grown significantly every year since then, and today it's one of the premier centers for ALS care and research in the entire state of New Jersey. The team is constantly looking at ways to grow and to providing the best ALS care to contribute to clinical trials. Dr. Sedarous has her own impressive background in medicine. She graduated Bachelor of Science in Neuroscience at Dalhousie.
That's correct.
Nailed it. I practiced it before. University in Nova Scotia in Canada. And then she earned her Doctor of Medicine from Ross University in Dominica and later completed her Neuromuscular Fellowship at the Weil Cornell Medical Center for Special Surgery in Manhattan, New York. As you've seen from the impressive list of presenters at this year's Help and Hope, Dr. Sedarous is another example of the exceptional care and research offered right here in our region. The most important endorsement is from our ALS families who speak highly of Dr. Sedarous and her team. In her presentation today, Dr. Sedarous will speak about ongoing trials at her center, including phase 2 placebo trials. Please join me in welcoming the very humble, that I could say all these things right in front of her, Dr. Sedarous.
It's really an honor to be here and to be asked to speak and share about a little bit about our clinic. I have some of my team members here, and that always gives me peace to know that we are here together. We've always been together since we started. You probably don't know where Dalhousie is, but it's like north and all the way to the east, closest thing to England, but on the Canada side. That's where I started, and I've always had interest in neuroscience, so even my undergrad was in neuroscience. Somewhere in between undergrad and medicine, I was also doing bench research. I did my master's in actually cell death and particularly in stem cells. So I was the poor gal that was killing the rats and dissecting them and taking the cells and making little neurons in a petri dish and seeing how they die. So that was a lot of fun, but I felt that it was very far from like patients, and it felt like it would take years to get to actually make any sense of any of that stuff. And that's what really led me to more clinical and medicine. And when I went to medical school, I said, okay, enough of neurology. Let's just do something completely different. And I just kept getting drawn to neurology. And from there, particularly peripheral nervous system, and from there, particularly ALS. So before I moved to Jersey, I did my training in Hospital for Special Surgery in a joint program with Weil Cornell, and that's where I really got to see ALS patients and got to learn about the disease. And I was fortunate enough to work with someone who was an ALS expert, and it just stuck to me since then. And I knew that whatever I was going to do later after that, it was going to somehow involve ALS patients. It's a very unique disease, very interesting disease biologically, and a very unique population, I feel, not just the patients, but also their caregivers. So I moved to Jersey thinking there must be some great ALS care here, and I was surprised to find out that there was a big void. So first, I know that most people here are from New Jersey, but if you're not from Jersey, maybe you put your hand up so I know if you're not from Jersey. Okay, all right, so you get a little bit of geography. This is the state of New Jersey, and we have great beaches, a long coast, right? We're also very fortunate to be in between two great other states, New York and Pennsylvania, where there is great academic centers that deliver a lot in terms of ALS care and research. And although that is a really good thing, it's kind of also of a bad thing, because a lot of the patients who were, when I first moved to Jersey, I came to know this, a lot of the patients who were living in the state of New Jersey were traveling outside of state to get their care for ALS. And although that is great at the beginning of the disease, as you know, it gets harder and harder and harder as the disease progresses. And it was very obvious as a young attending for me that we have to do better in our state. So that red star that you see is where, just for you to get a concept of where things are, that's where we are. It's about an hour and a half, 2 hours if you hit traffic like we did this morning, from where we are right now. And you can see how in close proximity to New York this is. This is a picture of our campus. So Jersey Shore University Medical Center is about a 700-bed hospital. The big building that you see that says Hope Tower is a brand new building that is dedicated only for research, and it also houses some outpatient testing. The Amdor Pavilion is where we currently live at the Neuroscience Institute. Across the street from that is where we used to be since we started in 2016, but we moved in a new space because our clinic has grown quite a bit. So a little bit about our clinic. I started the clinic in January 2016. I was about 6 months pregnant at that time with my third child, and I met this wonderful team of people here, and we've been together since then. We have always been a clinic that starts from diagnosis all the way. We don't only just care for ALS patients, but we also diagnose, and we stay in their life, and sometimes even with their caregiver's life. If you don't know Joan Dancy Foundation, I'll tell you a little bit about Joan Dancy. They're actually the ones that sort of promoted us to start the clinic. So Joan Dancy was an ALS patient way before I have known her, but she had also, I suppose, noted that there was not a lot of care in the state of New Jersey, and her husband, after she passed, made the legacy of starting this non-for-profit organization that serves patients with ALS, and it's made of right now a social worker who's wonderful and sitting right here, Kathy Valentino, and Pat Schaefer, a nurse, and they are, I call them our angels, because they are an extension, I feel, of our clinic in terms of the services that we provide. So we've collaborated with them since the beginning, and we continue to do so in many ways. We were designated as a Center of Excellence in 2021. I believe we were the first clinic that did that certification remotely because it was still COVID time. It was challenging, and we had to be very innovative, but we did it. And like I said, we moved to the new space because we're outgrowing our space in 2022. We feel that the awareness for ALS in our state needs to also happen at the political level, and we've collaborated with ALS Mid-Atlantic, Tony Hale, to bring awareness on the political level to try to change some of the policies to benefit our patients and their caregivers. When COVID started, we started televisits, and we feel that now it is an integral part of our clinic as well, and it's a way for us to reach patients beyond them always trying to come to our clinic. We always try to make an effort to be able to reach patients and not just wait for them to cross the doors into our center. We've also been members with NEALS. NEALS, obviously, Northeast ALS Consortium. We've been collaborating and members of NEALS since 2017, which gives us the opportunity to participate in NEALS-sponsored trials, and allows us to be at the same level as any other ALS multidisciplinary clinic in the nation. We contribute to some of the committees, the PTOT brochures for NEALS. Our PTOT members have contributed to them, so on and so forth. I personally like being part of the Technology and ALS Committee, and I participate in that committee as well. So this is our multidisciplinary clinic. As you can see, we have our own social worker. We have a speech and language pathology, but we also, I'm going to talk a little bit more about this, we also have our own AAC specialist, which is a unique program that we have in our clinic, and we're very proud of. We have respiratory therapists. We do all our PFTs in the clinic, and obviously we also have the registered dietitian and PT and OT. But beyond the clinic, we also collaborate with a few other things. I told you a few other agencies. I told you about the Joan Dancy Foundation, but also Bridging Voices. And Bridging Voices, if you don't know what it is, it's a program that is in the state of New Jersey that is non-for-profit and is another layer to allow for patients to have a voice who cannot communicate. They don't go physically into patients' homes, but with televisits are able to help you sort of make your home smart to some extent, or train you to use your AAC devices, and we work with them within the state. We also have a palliative care team that we work with that can do in-home services, a home care program, and we also house the support groups that are run by the Joan Dancy Foundation. So a few years back, we were fortunate enough to have a grant from the Christopher Reeves Foundation, which we used to build our loaner AAC program. And if you don't know what AAC stands for, it stands for an augmentative and alternative communication. It's any device that allows a patient to find an alternate way to communicate. Obviously, these programs are not specific to just ALS. They help many other neurological in many other neurological diseases. And not a lot of clinics have their own AAC programs. And we are fortunate enough to have not one, but two AAC specialists that are present in every clinic and are able to help patients find the right devices to communicate as the disease progresses, and even prior to that when they still have their voice. Including guidance for voice banking and programs like that. We were able with this grant to also have loaner devices. We have two Tobii Dynavox devices that we loan patients if their insurance is not allowing them to get them, or if their disease is progressive too fast and it's taking too long to get those devices. Like I said, we work very closely with Bridging Voices. As well to that, the AAC program is not only within the clinic, but also in the patient's homes. And we also, we're very keen to bring the research in New Jersey so that patients don't have to travel to be part of clinical trials. And so we have on the 9th floor with a beautiful view, our floor where we do the ALS research, and we have two dedicated research team members to help with recruitment and retention. We've participated previously in a number of trials, and currently we have a phase 2 clinical trial that I will tell you a little bit about, and I'll try not to bore you too much because I know it's the last session and everybody looks sleepy. So we are also fortunate enough to be part of a bigger network. So Jersey Shore is one of many other hospitals within the network of HMH or Hackensack Meridian Health. So the other ALS Center within our network is the other Red Star by closer to Newark. It's not actually in Newark, it's further up north from that. That is within the Hackensack University Medical Center. They have their own multidisciplinary team as well, and these are the members of the team. They collaborate with, they have their own pulmonary doctor that assists, as well as their own palliative care team. And they're also members of NEALS. They do have some research right now. They're part of the Healy clinical trial. They work with the Biorepository Steering Committee for NEALS. And they do have also a biorepository to identify patients with familial ALS. So you heard Carol speak from TDI earlier about the preclinical trials. If you remember her slide where she was talking about identifying drugs in a tube, and she took you all the way to an IND, and how FDA would then say, okay, you're allowed to test this. So now I'm going to walk you through that part after that. So once you've identified a drug that may potentially make a difference in a test tube or in a non-human scenario for a model of ALS, you can then go ahead and start into clinical trials. And it's not as simple as just taking a medication or taking a drug like that and testing it in human beings. There is phases to that. And I put this slide here to just make sure we understand what are the different phases of clinical trial and how much work really goes in until we can take one of those medications or one of those drugs and deliver it to a patient. So often after this slide from Carol, often a drug company with interest in one of those chemicals will perform either a pilot trial or they will go straight ahead into a phase 1. And then a phase 1 trial really is only for the purpose of making sure that this chemical you're giving to humans for the first time is not dangerous and is not lethal. And it's usually tested in a very small group of people, usually no more than 20 people, and the purpose is only to ensure safety. It's not really an empowered study to make any conclusions about whether a drug is effective or not effective in a disease process. Phase 2 is where you start to make some deduction regarding the results of a specific chemical in a disease process. Usually these tend to be in a little bit more patients than 20 patients, a few hundred, and we still continue to gather data about safety and tolerability in a patient population and start to see if it's worthwhile pursuing this into a phase 3 clinical trial. Now, although most of the time FDA will approve a drug after going through a phase 3 clinical trial, there are some exceptions, and we've had some of those exceptions recently, but some exceptions where they're approved after a phase 2 clinical trial. Mostly, especially in orphan diseases that are devastating like ALS, the FDA will make an exception if there is a clear trend that a specific drug is helpful. But more typically, it's after a phase 3, and a phase 3 is when you really get to test it in a much larger group of people. You do a much more comprehensive assessment and are able to say for sure if a drug is helpful or not. Oftentimes, we do a phase 4, so that's sometimes the FDA will require that if the drug still needs to be monitored in terms of efficacy or in terms of monitoring safety. And so that's not all drugs go through a phase 4 clinical trial, but sometimes the FDA will request this or require this. So this very confusing slide is just maybe the biggest take home from it is how complex this disease is. And I'm obviously not going to go and bore you and put you to sleep with the details of every part of it, but I want you to just picture for a minute what a motor neuron does, right? So it's the motor system in a human being is made of 2 major neurons. One is the upper motor neuron. You may have heard this term. And it's a neuron that starts in the motor cortex and goes all the way down into the either spinal cord or the brainstem. And then the second neuron is the lower motor neuron that goes from that first neuron, that synapses with it, and it goes down to a muscle, a targeted muscle. A muscle could be in the arm, it could be in your legs, it could be in the bulbar section or head and neck area. This, you would think, of course, looks like it's a lower motor neuron because it's connected to a muscle at the end. These neurons extend for very, very long distances. The top part with that circle is the nucleus where the DNA is. And it has to make all the proteins that will have to go all the way down this path to the distal portion or the last portion of the neuron before it makes an effect into a muscle contraction. So a motor neuron is a very highly efficient and a very busy cell that makes so many proteins and so many effective ways to deliver the signal from the top all the way to the bottom, and have to do it so efficiently to execute a specific motion. So many things can go wrong in a motor neuron. And you may have heard this earlier today that a lot of times by the time a patient comes and presents with symptoms of weakness, they have already lost a significant number of those motor neurons. That's because we have a safety mechanism where we make so many more than we really need, and that it takes that much to die back before we actually see weakness. And so realistically, I say this because realistically, when we're testing a drug in a patient who already has been diagnosed with ALS, we are fighting time because the disease process started potentially maybe months to years before that. And so it is not easy to see if a drug is really working or not because you've already wasted a lot of neurons. So, and most of the time your goal is to preserve function because bringing back those neurons is so hard because that nerve or that cell has to grow from wherever it started dying, from like your spinal cord all the way to your toe. So that's a great distance, and nerves just don't do that very well. So I wanted to say this so that you understand the complexity and how hard it is to find now a drug that will reverse that process. So I guess a few things that are important to talk about, or I want to highlight here, where it says neuroinflammation is one of the things that happen. Neuroinflammation is important because it's one of the reasons why we think some people are faster progressors than slower progressors. There is evidence that inflammatory markers are higher in patients who are faster progressors. Thank you, Steve. You've seen medications that work on oxidative stress or reducing the amount of oxidative stress in a cell. For example, Radicava, which is FDA approved, is one, or edaravone is one of those medications. Excitotoxicity is a term that is, I think, important to just explain for a minute, where you have an excitatory chemical or neurotransmitter that is too much that it causes some level of toxicity and cell death, and that's another factor that we feel contributes to the disease process. And so as you hear today, antisense, antisense is, we spoke about antisense earlier with Dr. Quinn, and that is targeting specific gene expression. But there is so many other places that we can potentially intervene to slow the progression down. It is important to appreciate that no two ALS patients look the same and start the same, and there's got to be a reason for that. There's got to be a reason why some people start bulbar or some people start limb, and we still don't have really 100% understanding of what drugs work best for which patients because we don't have all the facts or all the biomarkers clear yet. So still a lot of work. We've come a long way, but a lot of work to do for ALS. So now that you have this complexity, I'll talk to you a little bit about our phase 2 clinical trial. I love the name because it's dazzling, dazzles, I like it. So it's a phase 2 multi-center, it's a randomized double-blinded placebo-controlled study of a chemical called dazucorilant in patients with amyotrophic lateral sclerosis. It's dazzles, I think, is a lot nicer to say. A little bit about the basic background why we are interested in this chemical. And so we'll talk a little bit about cortisol. And cortisol is a normal chemical that your adrenal glands make. It is considered it's considered a stress hormone because when you're stressed or you're sick or something is happening, high levels of cortisol are correlating with disease activity. In ALS also, we feel that it has been shown that patients with more progressive or fast progressors of ALS tend to have higher levels of cortisol. We normally make cortisol in a sort of diurnal fashion, right? So there are certain times of the day that we make cortisol more, and then certain times of the day when we make less of it. But the overall amount of cortisol levels are felt to be elevated in patients with ALS who are fast progressors. So what, you have a little bit more cortisol than you should. Well, that's been linked to a number of things. One is increasing inflammatory effects in the brain and the central nervous system, activating or increasing the amount of glial cells, which are important in the disease process of ALS. And back to this excitotoxicity term, it's been shown that it correlates also or promotes increased level of that excitatory neurotransmitters that can then lead to neuronal toxicity. So there is basic science rationale why looking at cortisol in patients with ALS may be of importance. So the chemical that was developed is called dazucorilant, and it's a relatively small molecule that sits on a receptor called the glucocorticoid receptor modulator. Because it's small, it's relatively easy to cross into the brain, and that was demonstrated in rats, and also detected in the CSF, or the cerebrospinal fluid, which is the fluid that runs around our brains and spinal cords in human. It is very selective to the glucocorticoid receptor, which is important because you don't want to affect all the receptors of glucocorticoid, because then that would be potentially dangerous for human beings. So you heard earlier also about the SOD mice, which is and has been for a long time the mice model of an ALS, but there's other mice models of ALS. One of them is the wobbler mice, and these mice actually have adrenal hypertrophy and high levels of glucocorticoids, similar to patients with ALS. And so we tested this, and I'm sorry about the slide. I don't know why it's overlapping, but we tested this dazucorilant in mice, and we found that it was able to improve the overall homeostasis of glutamate, that same excitatory neurotransmitter that we were talking about that causes excitotoxicity, that it decreased or modified the neuroinflammation in these rats, and overall negatively modulated the cell death that happens in the ventral horn, which is where the motor neuron sits in rats. So it was a good rationale to take it into clinical trial, and so that's what we're doing right now. We're doing a phase 2 trial, which means that we're testing efficacy to some extent, but more importantly, the safety profile in patients with ALS. We were a little behind starting this in North America. Europe started ahead of us, and so a lot of the enrollment came from Europe. But our site was kind of waiting and ready to go once the FDA approved it here, and we have been participants of that trial among other sites in the US. The target enrollment has been achieved. It's 228 patients. We closed a new enrollment already, and we're testing 2 different doses, and so because it's a placebo-controlled, that means that a group of patients will have placebo. Another group will have a reduced dose of 150 milligrams per day of dazucorilant, and another group will have 300 milligrams per day of dazucorilant. This clinical trial also has an open label extension. So again, what that means is that after 24 weeks of being either in placebo or the 150 or the 300 group, everybody after that goes on to be on the medication, and for another 132 weeks. So some of the things about this trial is that you have to be able to swallow, and it uses a slightly different way for inclusion, something called the TRICALS, which is fortunately not very restrictive in terms of how long you've had the disease. It's a form that looks at a combination of points achieved from vital capacity, onset of symptoms, FRS score, and so on and so forth. Primary endpoint, of course, because it's a phase 2, is going to be, first of all, safety, but we're also looking at the FRS score, ALS FRS score. That's the same score that you guys are familiar with, that we do in clinic every visit. Secondary endpoints, we're looking at lung function, quality of life measures, and the muscle strength. That's not even all my team, so you can imagine how much we've grown. Some people couldn't find pictures of everybody, but so this is Most of my team, but not everybody. Of course, because this is a phase 2 trial, we don't have data to share yet, but we are still kind of in the trial, but we will be looking forward to the results of that trial hopefully soon. I made it short so that you guys can go home and not fall asleep on me. So I think I managed. I was not as funny as Dr. Quinn, but at least nobody slept on me, so that's good. We are going to be walking Seaside Heights, so if you want to come to the shore and walk with us, we will be there. I'll take any questions if you have them. Any questions? Yes.
I do. So it says that they have to be able to swallow and they're able to tolerate the soft gel. So if at some point, like let's say they're having the placebo and their disease progresses, they're not able to swallow, is there any other route for the medication?
They have to be able to swallow. Unfortunately, they have not come up with a solution for patients who progress to the feeding tube. Yeah, but I think they are working on something for that, but right now you have to be able to swallow. Yeah. Yes.
The 228 patients in
Yes.
this phase, how many are at your clinic?
A small percentage. So actually 80% of the recruitment happened in Europe because they opened almost a year before it was even allowed to come to the United States. So a very small portion compared to the big population. But we're fortunate to at least be able to have some US data as part of that trial. But yeah, we were very behind and coming up, and mostly because of the FDA. Yeah.
When did it start?
The trial? Well, in Europe, it started about a year ago. We started recruiting in November, and we closed recruitment by March. Yeah, it was a very quick, very close, yeah.
In terms of endpoint or goal, what are they hoping this will ultimately look like in terms of its impact on?
I think they're hoping to show that the same thing that happened in the wobbler mice, that it would slow the progression, decrease cortisol level. They're measuring cortisol levels in patients, and again, because they're hoping that this would be something that would be helpful in patients with faster progression. I think the rationale is that they're hoping that it would slow the progression down in patients who would otherwise be fast progressors. Yeah. That's.
Do you see comparisons of cortisol levels in other diseases?
As part of this clinical trial, no.
Just in terms of your own knowledge.
Oh, yes. Yeah, so cortisol level is known to be elevated, and even if you have an infection, your cortisol level may go up. If you're going through a period of stress, the cortisol levels are going to go up, and that's been linked to a lot of things, including developing prediabetes or glucose intolerance and things like that. So the idea is not foreign in general from a medical standpoint of having elevated cortisol levels in a high disease state. Yeah. Any other questions? Yeah.
For the population in the study, is it familial, sporadic,
Doesn't matter. Doesn't matter, yeah. No restrictions from that standpoint. Good question. Anything else? It's been a pleasure. Thank you so much for having me.